Hello everyone, today we are going to discuss about a small topic of pediatrics, ventricular septal defect, VSD. So let's introduce about it. It is the most common congenital heart disease. Why it is the most common congenital heart disease? Because the ventricular septum formation is a complex process. That is, it consists of muscular and membranous fusion. So any failure in the fusion leads to its defect. So it is the most common congenital heart disease. Regarding incidence, it is more common in female than males. Ventricular septal defect is most common congenital heart defect complicated by infective endocarditis. That means in ventricular septal defect, there is left to right shunt, which during which the endocardium is damaged, and damaged endocardium, platelet and fibrin gets deposited where the bacteria get attached, leads to infective endocarditis. And clogging in ventricular septal defect suggests subacute bacterial endocarditis, because in simple ventricular septal defect there is no clubbing, but if clubbing appears, it suggests chronic infection like subacute bacterial endocarditis or Eisenmenger disease. Now let's discuss about the embryology of the ventricular septal defect. Interventricular septum is formed by the fusion of aorticopulmonary septum with muscular septum, and VSD occurs due to failure of fusion. Let's understand this point. Muscular septum grows upward from the floor of ventricle. Muscular septum grows upward from the floor of ventricle, whereas aorticopulmonary septum grows downward, and they fuse to form a complete septum. And ventricular septal defect is due to failure of fusion. If these parts fail to fuse, then there is opening and it leads to ventricular septal defect. And there are two types. One is membranous VSD, it is the most common, and muscular VSD, which occurs in 10%. Let's understand the hemodynamics of ventricular septal defect. At first, at the beginning of systole, left ventricle contracts before the right ventricle and pressure gradient is created, causing flow of blood to right, producing murmur, masking first heart sound. Now let's understand this point. Normally, left ventricle pressure is much higher than the right ventricle pressure. Left ventricle pressure is much higher than the right ventricle pressure. When systole starts, left ventricle pressure rises rapidly. Left ventricle pressure rises rapidly. Because of ventricular septal defect, blood moves from high pressure to low pressure. So from left ventricle, blood moves to right ventricle. This is called left to right shunt. The blood passes with force, rapid force, through a small opening, which causes turbulence, turbulence, which causes turbulence. Turbulent flow produces the pansystolic murmur. Pansystolic murmur. What is pansystolic murmur? Murmur occurs throughout the whole systole. This is the pansystolic murmur. Since murmur starts immediately with first heart sound S1, so it masks the S1. First point clear. Now let's move to the second point. At the same time, right ventricle also contract and blood from left ventricle also stream more or less directly to pulmonary trunk. The shunted blood enters right ventricle. Okay, right ventricle contracts and blood is pumped into the pulmonary artery. So pulmonary artery now receives blood from normal right ventricle blood and extra blood from left ventricle. Therefore, pulmonary blood flow increases. Clear. Now let's move to the third point. This produces flow murmur at pulmonary area. What is flow? Flow murmur. This murmur is due to increased flow, not due to the defect in valve. So it is called flow murmur at pulmonary area. Clear. Now let's understand the fourth point. The increased blood volume in the pulmonary system returns back to the left atria and to the left ventricle. Increased blood volume in the pulmonary system eventually returns back to the left atrium after oxygenation, and through left atrium blood enters to the left ventricle via the mitral valve. Clear? Now this produces delayed diastolic murmur at the apex and large S1 because more blood passes through the mitral valve during diastole, which increases the flow across the mitral valve, and mid diastolic flow murmur at apex is heard. Because of diversion of blood to right ventricle, the blood in the left ventricle impedes early in systole, producing early A2. Now, because of diversion of blood to right ventricle, the blood in left ventricle impedes early in systole, producing early A2. Some left ventricle blood escapes to the right ventricle instead of going to the aorta. So left ventricle impedes much faster. So aortic valve closes slightly early and early A2 is produced. Now let's summarize it. Left ventricular contraction, blood moves to right ventricle, left to right shunt, pulmonary overcirculation, more blood returns to left atrium and left ventricle, left heart volume overload, flow murmur. Now let's understand the clinical features of ventricular septal defect. First, symptoms. Symptoms occur at the age of 6 to 10 weeks with features of congestive heart failure. Why at 6 to 10 weeks? Because at birth pulmonary vascular resistance is high, but after 4 to 6 weeks pulmonary vascular resistance is low. So now the left ventricle pressure is much higher than the right ventricle pressure. So there is ventricular septal. Symptoms of ventricular septal defect is seen. Second, frequent chest infection. Why frequent chest infection? Because due to increased pulmonary blood flow, there is pulmonary congestion, and in wet lungs there is repeated respiratory infection. Shortness of breath on exertion. Why shortness of breath? Because due to pulmonary overcirculation, which decreases the lung compliance. Palpitation due to hyperdynamic circulation or due to volume overload. And failure to gain weight. Why failure to gain weight? Because increased metabolic demand due to congestive heart failure, or baby is not feeding well, or due to recurrent infection, there is failure to gain weight. Now let's understand about the signs. On inspection, there is bulging hyperkinetic pericardium. Why? Because left ventricle volume is overloaded and it appears enlarged, forceful cardiac activity occurs. So visible chest wall movement is seen. On palpation, systolic thrill. Why? Because high velocity turbulent flow through the ventricular septal defect and thrill is felt at the left lower sternal border. And if there is a small ventricular septal defect, loud murmur plus strong thrill is palpated. And on auscultation, S1 is masked by murmur. We have already discussed about it. S2 is masked at left lower sternal border, but audible at left second intercostal space. S3 may be audible at apex. Murmurs ausculted at ventricular septal defect are shunt murmur and flow murmur. Shunt murmur, pansystolic murmur in left lower sternal border. Why? Because left ventricle pressure is more than right ventricle pressure throughout the systole. So murmur lasts entirely the systole. That is called pansystolic murmur. And next is flow murmur. Pulmonary ejection systolic murmur. Why? Because increased blood passing through the pulmonary valve, not due to the stenosis. It is due to the increased flow. That's why it is pulmonary ejection systolic murmur. And mitral delayed diastolic murmur at the apex. Why? Because extra blood returns from lungs and there is increased flow across the mitral valve. Causes mid diastolic flow murmur at apex.